Welcome to Learning Thursdays. I'm Dean Hale with the OASAS Learning and Development Unit and your host for today's presentation. Today's presentation is titled Gambling and Behavioral Health Conditions. And joining me today is New York State OASAS Commissioner Chinazo Cunningham and Associate Chief Medical Officer for Addiction Psychiatry for New York State OASAS, Dr. Grace Hennessy. They'll be joining me in just a moment, but first, a word about Learning Thursdays. Learning Thursdays are offered to behavioral health professionals as a free learning opportunity with the goal of improving the knowledge and skills of the New York State substance use disorder workforce as we strive to improve the lives of individuals needing prevention, treatment, recovery, and harm reduction services. A goal of Learning Thursdays is to support the professional development of the treatment, prevention, recovery, and harm reduction workforce. We do this by offering regular presentations that are relevant to today's substance use disorder treatment professional. As always, if there are any questions, comments, or suggestions, please feel free to contact us at the Learning Thursdays mailbox. You can use the same mailbox to express an interest in providing a future Learning Thursdays program. And now it's time to start the presentation and welcome our guests.
Really happy to be here today to kick off this learning collaborative on problem gambling. So thank you everybody for joining this morning for the fourth problem gambling learning collaborative. So as you know, I hope many of you know that we really have refocused some of our efforts at OASAS to really focus on the potential harms associated with gambling and to increase awareness within the end-to-end care and access to care in the OASAS system, so that hopefully all of you are here to sort of learn about that and really help us all improve access to services for problem gambling. I think as many of you know, there's wide increases in the amount of gambling that's happening across this country and across New York State. We have 3 new casinos that will be opening up downstate. We certainly have online sports betting, and all of that together really, increases the potential risk for harms associated with gambling. So for those who missed the first 3 learning collaboratives this year, we focused on how to identify problem gambling, how to screen and assess for problem gambling, and then how to provide a gambling designation on your operating certificate so that you can provide much needed services. So all of these have been recorded, and there's free CEUs available, and that can be found on our Learning Thursday website. And just as a reminder, at OASAS, we provide care for anybody who has issues with problem gambling, and that can be through our designated outpatient programs as well as our private practitioner network and inpatient services at the addiction treatment centers. So, if you are a program or provider, I strongly encourage you to consider applying for this gambling designation and really working with our Bureau of Problem Gambling, with your regional office, and with the local Problem Gambling Resource Center. So everyone is here to help you through that process. The application process and the requirements are pretty simple, and they're no additional cost to you. In addition, just as a reminder that in January of 2023, OASAS providers are now able to bill Medicaid for gambling use disorders only, so people do not have to have a substance use disorder along with that gambling use disorder. And in addition to this learning collaborative, where there's a lot of other activities that we're focused on, including a podcast on problem gambling, and really working across the state partners to obtain data, to get better understanding, to increase awareness. During the month of March, we had a problem gambling awareness month, where we're promoting screening and assessments and really raising awareness. And then in the upcoming months, we're also going to be working with our other collaborators across the state to do a responsible play partnership, and so having some press conferences across the state. So we are going to continue these learning collaboratives across the year, and if you have any topics that you want to discuss, we'd love to hear about that too. So what we do know in terms of problem gambling also is that there's risks of behavioral health problems. And so, this is really important today when we're focusing on those, the sort of intersection between gambling and behavioral health conditions. And that's going to be led by Dr. Grace Hennessy. But before turning it over to her, I just want to acknowledge our team at OASAS under the leadership of Pat Lincourt and Rebecca Cooper and others in the Bureau of Problem Gambling. We're really here to help all of the programs really to support you to do this work and really to support New Yorkers. So thank you again for participating in today's Learning Collaborative. Yes, I saw on the chat, the other ones are recorded. There's 3 other ones, so they're on the Learning Thursday website, so please check them out. And now I'm going to turn it over to Grace. Thank you, Grace.
Thank you, Commissioner Cunningham, for the introduction, and thank you all for coming today. It's a pleasure for me to be able to talk to you about this subject. So for our presentation today, we are going to just have a review of what gambling is and gambling disorder. Since some of you may not have been at the other ones, the other collaboratives, just want to make sure we're all on the same page with that. Then we're going to review the gambling and behavioral health conditions and the relationship between them, with a particular focus on gambling and suicide. And then we're going to finish up talking about suicide screening and safety plannings for those who are at risk for suicide. So we're going to have a question first. And I realize now that I'm sharing my screen, I can't see the chat. So I'm not going to be able to see everybody's answers when they get put in, but I'm going to start with a question for you all. So we have a true or false. Casino table games are the gambling activities most associated with problem gambling. So this is a true or false. You can put in your answers into the chat, and we will get back to that. So I should have said also, when I say casino table games, I mean things like baccarat or craps or blackjack. So in the casino, playing on the games. Okay, so gambling defined. So gambling is a very straightforward definition. It really just means risking something of value for the chance of a reward. So this graphic kind of shows you how that works. And really something of value that you're risking isn't necessarily always money, right? So sometimes people might bet a prized possession, or sometimes people even put their reputations on the line with things. If you like sports, usually for the World Series, or for the Super Bowl, you'll see the mayors of the cities or the governors of the states have these they make these wagers where the loser has to wear, the losing states has to wear the winning state's jersey for a whole day, and that's a form of gambling. But again, no money is being changed hands. It's just more about sort of reputation and having someone do something that they may not have otherwise chosen to do. There are many types of gambling and gambling activities. This is just a major example of all different types. So there's video lottery, dice and card games, internet gambling, pull tabs and scratch off tickets, sports wagering, games of skill, bingo, raffles and office pools, and lottery games, really just to name a few. And when really you look at the gambling literature, a lot of times what they do is they kind of group these different types of games. And you'll see over here, we talk about already games of skill. Sometimes these are also called in the literature strategic games. And these are the types where if you have do some study, or if you have some knowledge of it, you can sort of put it to the game, and you can maybe increase the odds that you might win something. So things that fall under that might be things like having a fantasy football team or fantasy baseball team. Some sports betting, even actually horse racing wagering would be another example. And then there are games that are considered games that are not strategic, or games that don't involve any skills. So that would be things up here like bingo, lottery games, electronic gaming machines or slot machines. And there's a whole sort of gamut of those as well. So those you can't really study for. You are at the sort of mercy of what numbers are drawn or what comes up on the pull of the handle if you are doing a slot machine. In addition to the spectrum of gambling activities, there's also a spectrum of gambling behaviors. And that ranges from non-gambling, which we consider people who do not gamble at all. In the gambling literature, they consider people who gamble maybe sometimes, sort of infrequently, type of person who buys a lottery ticket when the prize is quite high, like there was recently in New York State and around the country, to be non-gamblers. Then when you start to have a few problems related to your gambling, you move into at-risk gambling. And as the problems grow, you move along the spectrum from at-risk to problem gambling, and then over into sort of one of the most serious outcomes of gambling, which is developing gambling disorder. There has been a lot of interest recently in gambling activities and how they relate to problem gambling. There was a study that was done in 2021 and really looked at a myriad of factors that make up what go into a human being and how they might relate to gambling and problem gambling. So this included age, this included religious affiliation, marital status, socioeconomic status. Ultimately, they had 57 different factors that they looked at. And the number one factor that they found that led to problem gambling was any kind of internet gambling. So anything that people were doing on a computer and the internet was ranked the highest. After that was electronic games and slot machines, followed by poker, and then casino table games. So I could see a little bit of flashes up in the corner of my screen, and it looked like a lot of people did say false for our initial question. And if you did, you're actually correct. So internet gambling is really the number one activity and the number one factor of human beings that have been found to be associated with problem gambling. And the reason for that, and probably the reason why electronic gaming machines and slot machines come in second, and those are the ones I should say that are casino based, is because there's rapid play, right? When you're on the internet, you're gambling, you're doing slot machines, you can just keep betting with more and more money. And particularly with the internet, now we have 24-hour a day, 7-day a week, 365 days a year gambling. So not surprisingly, something that's that available that you can bet on that quickly and over time would potentially lead to have the greatest association with developing problem gambling. As I mentioned earlier, one of the more severe things that we get concerned about in terms of people's gambling behaviors is developing a gambling disorder. So in the DSM-5, the Diagnostic and Statistical Manual for Mental Health Disorders, the 5th edition, and they recently had a text revision, which is what the TR means. Gambling disorder, was moved out of impulse control disorders, where it was things with like kleptomania, which is challenges with stealing things over time, trichotillomania, which is an impulse disorder where people pull out their hair, to be classified with the substance-related and addictive disorders group. And that was because they found over time that really a lot of the presentation of the disorders, the course of illness, the treatments that were used for it really were very similar to what went on with substance-related disorders. So it was moved into that category, and the name was changed from pathological gambling to gambling disorder. And pathological was dropped because, not surprisingly, that was very pejorative and people found it quite stigmatizing. We don't use in psychiatry pathological for any other type of disorder. So it was renamed as well during that time. And the criteria, just to go through briefly, you need 4 out of 12. There's persistent and problematic gambling behaviors leading to significant distress. And it was really instrumental in allowing for recognition of this as an addictive disorder and Medicaid billing in New York State. It also increases the amount of money that becomes available to people who do research in gambling disorder. So apologies, I jumped into my criteria quickly, so I missed the last point, so moving along. So again, there's persistent and problematic gambling. You also have preoccupation with thoughts of gambling, gambling with increased amounts of money to get sort of the same excitement, repeated unsuccessful efforts to cut back or stop. You're restless or irritable when you try to cut back or stop. You gamble as a means of coping with problems or uplifting mood. You're lying about the extent of your gambling, chasing your losses to recoup recoup the money or whatever you've lost previously. You're jeopardizing relationships, work, and school, and you're relying on other people to help you make ends meet or pay your bills. There also needs to be clinically significant impairment or distress, which is something that's really important when you think about any kind of disorders, because if sometimes people meet criteria for things, but very interestingly, they don't have distress or impairment because of it. So that is another important factor as well. And you have to meet 4 of these criteria again in a 12-month period. Studies have shown that people who live with gambling disorder do deal with a lot of harms, as we just mentioned, and some of them are linked into financial ones, so mortgage foreclosure, missed credit card payments, bankruptcy, not paying your rent. Then there are the more societal ones, your relationship issues, so marital problems and impaired family relationships. And then there's the ones that come along the medical and behavioral spectrum. So studies have shown that people with gambling disorder do have more medical issues, particularly hypertension and insomnia. And there's also increases and of depression, depressed mood, and major depression. And also the risk of suicide goes up. So now that we've laid the groundwork, we're going to switch over and we're going to really focus on those behavioral health issues, including things like depression and suicide. And now we are going to have another question for you all. So which substance use disorder most commonly occurs with gambling disorder? So people who have gambling disorder, what has the research shown to be one of the other disorders, the substance use disorder, that occurs most commonly? So I see some alcohol coming up. Again, it's a substance use disorder. So I saw some other stuff, alcohol, stimulants, drinking. Okay, so I see a lot of stuff's coming up. We're going to get to that in a minute. So I just want to give you a little background before we move on from this. So our knowledge of behavioral health disorders that occur with gambling disorder really come from studies of the general population and from treatment populations, so people looking for treatment. But there is one large study that was done back in 2008 that gets cited fairly regularly in the literature. Unfortunately, it's incredibly difficult to do these large population-based surveys of individuals and related disorders. So we haven't had one for a while. We're sort of due for one. But the best one that we do have that looks at the United States is the one that showed that, and I didn't see this one in the chat, but I saw the second and third one there. It showed that actually nicotine dependence or tobacco use disorder is the main substance-related disorder that was seen in individuals who had gambling disorder. So if you look at this graph, this graph is again representative of the study I just mentioned, and you can see in the lead far and away is nicotine dependence. Again, that name also changed over time in the DSM, and we now call it tobacco use disorder. They are the same thing. And then if you look second, coming right afterwards are the other substance-related disorders, alcohol or drug dependence and alcohol or drug abuse. Again, terms we don't use anymore. Now, to be fair, if we added these two together, they would be longer than the nicotine dependence. But again, this study showed, and we'll see that other studies have showed, that nicotine dependence or tobacco use disorder is the number one disorder that people live with. These disorders that are now down here in this orange color really represent a cluster of anxiety disorders, and they are very high as well. So phobia, which is sort of general fears of different things like flying and heights and so forth. There was very high representation in the population of individuals with gambling disorder, as well as panic disorder, PTSD, post-traumatic stress disorder, and generalized anxiety disorder. Also very high were the mood disorders, so major depressive and dysthymic disorder and bipolar disorders are considered mood disorders. High percentages of people reported those disorders as well in this survey. and then also was attention deficit hyperactivity disorder, which I saw someone mentioned in one of the disorders. So it is there, but it's not a substance-related disorder. So these were the main disorders in the U.S. population that were found. Again, this is an older study. Likely the numbers are probably similar, but there might be some shifting around since it has been a while. Similarly, when they looked at treatment populations, this was a 2015 study that looked at a large number of studies that showed that people with gambling disorder who came to get treatment also reported a lifetime history of gambling disorders. And the highest rates, once again, were nicotine dependence and tobacco use disorder. And then things get a little bit shuffled around here. Anxiety disorders got moved down a bit, which was higher in the US population of the general population. Mood disorders sort of moved up, and alcohol use disorders was close as well. Anxiety disorders, and then a small percent had all other non-alcohol substance related disorders. Interestingly, in this study, ADHD really did not come up high, but it has come up in other studies. So it is something we do consider and think about in the ranking of disorders that co-occur with problem gambling and gambling disorders. So what is this relationship? What do we know about it? People talk about the pathway model in the gambling literature. And what that means is there's sort of two pathways that often people go along when they develop gambling disorder and a co-occurring condition. And the first is gambling disorder develops first. So that means someone gets in trouble with gambling and they have gambling problems. And then the adverse outcomes related to their gambling and the gambling disorder contributes to the development of the co-occurring disorder. So you could see that maybe someone has a gambling problem, their mood gets low, they feel down, they aren't sleeping well, and they move into developing a full episode of major depression or one of those anxiety disorders that we mentioned. I did see someone had their hand up. I will get to questions at the end. So just hold on to your thoughts and we'll get there eventually. And again, the other pathway that people go through is that they get the co-occurring disorder that develops first, and then gambling is a coping strategy for the co-occurring disorder symptoms, and over time it develops into an independent problem. So again, some people may have anxiety and they actually deal with it by gambling. And there's some very interesting literature that looks at veterans with PTSD, and there's a number of them who do use gambling and develop gambling problems because it was sort of a way to get away from sitting with the symptoms. The interesting thing with ADHD is that we think that that comes from the impulsivity. So likely with ADHD, it does go where the co-occurring develops first, and the impulsivity that's part of the disorder gets involved with the challenges of gambling, and the impulsivity moves them into a gambling disorder. When people have co-occurring disorders, either it's just a substance-related disorder or a mental health disorder or both, we see poor outcomes when they occur together. And among them are more years of gambling problems, more frequent gambling, more mental health symptoms, more mental health treatment, more frequent substance use, more episodes of substance use treatment, more severe legal problems, more severe family problems, and people with co-occurring disorders are also more likely to be unemployed. So now we're going to talk about suicide and the relationship between gambling and problem gambling and suicide. And we're going to have one last question for this talk. And the question is, gambling and which psychiatric disorders carry the greatest risk of suicide attempts? And again, if you want, you can put your answers in the chat. Okay, I see a few coming up, see a lot of depressions coming up, major depression. Okay, so people can keep putting them in the chat and we'll keep moving along with them. So suicide is probably one of the worst outcomes that can happen to people with any type of disorder, be it medical or psychiatric. And gambling really is no different, that people with gambling disorder are at an increased risk of suicide. Before we get into the co-occurring, we'll look at gambling alone. And what they found in the research is that people with gambling disorder are 4 times more likely to have suicidal ideation, 6 times more likely to have made suicide attempts, And in one large study out of Norway, they found that individuals with gambling disorder were 15 times more likely to die by suicide. So if they were someone who had ideation and made an attempt, the likelihood that they made an attempt that was lethal was quite high when compared to people in the general population who did not have gambling disorder. This is actually a number that is found to be higher than what we see for individuals with just substance-related disorders in surveys and in studies where they looked sort of similarly at individuals who died by suicide and looked at the co-occurring substance-related disorders they had and the increased risk that put on that. The numbers sort of range up from like 6% to about 11% as 11 times, 6 times to 11 times as the numbers of disorders sort of increase. So the more substance-related disorders you had, the greater the risk you had of suicide, dying by suicide. So this is just one study. I do want to point it out. This was one study in Norway. Obviously, more needs to be done, but this study was fairly recent, and you'll see it a lot in the literature that you read about gambling and suicide. So again, if people had a gambling disorder, they had suicidal ideation, and they made an attempt, they were 15 times more likely than others to die by suicide. And when they looked at gambling activity in a study of treatment-seeking gambling disorder population, they found that suicidal ideation and attempts were more common in non-strategic gamblers. So if you remember about 10 minutes ago, I mentioned the issue of non-strategic gambling. So those are those games where you really don't have much of an opportunity to affect the outcome. So things like playing the lottery, scratch tickets, slot machines, so things that really, again, the odds are really not in your favor and are very much, the chances are very much not influenceable, that those individuals were more likely to have suicidal ideations and make attempts. So 82% had suicidal ideation in this population, and 88% had made suicide attempts. And again, in some ways it makes sense because these are the games, again, where you can do continuous play, you can lose a lot of money very quickly. So that would sort of ramp up the likelihood that you would have problems. And then the more problems you have, the more likely the disorder, and then moving you into a place where you may have suicidal ideation and make attempts. And looking more specifically at criteria, it has been found that the severity of lifetime gambling increases the risk of suicidal ideation. This was a study from 2015, and I will point out this did use, because I'm quoting a study, I did use the former term of pathological gambling. Again, this term has been retired, and this would be equivalent to gambling disorder. So what they did was they looked at a group of treatment-seeking, they looked at a group of treatment-seeking individuals and compared them to the general population, and split them up into 4 groups: non-gambling, at-risk gambling, problem gambling, and pathological gambling or gambling disorder. So that continuum we talked about earlier, and they looked at the number of criteria that people met in terms of the criteria at that time for pathological gambling, and looked at the risk of suicidal ideation. So people who really didn't gamble or didn't have gambling problems really didn't have any increased risk in suicide. But as the problems increased, the risk of suicidal ideation increased, going from 1.2 to 1.6 to 2.9 times greater than the general population when they looked at these individuals. So again, the severity of your gambling increases the risk of suicidal ideation. And the same study found that it also increased the risk of suicide attempts. So once again, for the non-gambling and the at-risk gambling groups, there wasn't really an increased risk of attempts. But you see, once people really get into challenges with their gambling problems and so forth, and as the number of problems increase, the risk goes from none to 2.5 times. And then up to 2.8 times. So again, the severity of your gambling problems seems to have a notable effect on the risk that you will have suicidal ideation or make attempts. When you throw co-occurring disorders into the mix, it gets more complicated. So when someone has a gambling disorder and a co-occurring disorder, like the ones we've mentioned earlier, the likelihood of suicide attempts, again, goes up. So I did see there was a lot of depression that was in the chat. That came up as the disorder that had the highest risk of suicide attempts. And actually what the research has shown is that it is for all kinds of drug use disorders. So if you put in a drug use disorder, you were correct. So there's about a 4-time increased risk of suicide attempts when you have gambling disorder and a co-occurring drug use disorder. Now, to be fair to y'all, mood disorders were quite quickly after that one. They were right after that. It was 3 times the disorder, 3 times the risk for mood disorders. So if you said depression, you were definitely in the range. Then it goes down to 2 times the increased risk for people with alcohol use disorders and gambling disorder, and the same for anxiety disorders and gambling disorder. To focus on major depression, because it is the most common psychiatric disorder that we do see in the United States and around the world. There was one study that looked specifically at major depression and problem gambling and suicide. This was a 2021 study that looked at hospitalized patients with major depressive disorder. And those with a gambling disorder, a secondary diagnosis of gambling disorder, and those without a secondary diagnosis of gambling disorder. And 2 of the key findings, interestingly, was that major depressive disorder patients with gambling disorder were also more likely to have alcohol use issues. So the other important thing that came out of this study was that it shows, we've been talking about this very neatly in this talk, that, well, people have gambling disorder and an anxiety disorder, or major depression or bipolar disorder. But really, a lot of times there's things that the co-occurrence is not just with one disorder, it can be multiple disorders. So the individuals with major depression who had gambling disorder were also more likely to have alcohol use issues, not necessarily meeting the criteria for disorder, but they had problems with alcohol. So it was important to note as well. And what was the main takeaway was that the co-occurring gambling disorder appears to increase the risk of suicidal thoughts and attempts among those with major depressive disorder. And this just shows you their findings in sort of graphic form. So the blue bars are major depressive disorder without gambling, major depressive disorder with gambling. And again, these were for gambling disorder. I don't know why they didn't put disorder up in the, it's down here, but they didn't put it up in the legend. And you can see there was a notable difference in the percentage of individuals, again, who did not gamble versus the individuals who had gambling disorder. In the percentage who had lifetime suicidal ideation, ones that had made a suicide attempt. And then this just was adding the 2 together and showing the composite of individuals with suicidal ideation and attempts. Do want to point out that, again, people just with depression are at high risk for suicide as well. This was a hospital sample, so not surprisingly, because many times when people do get hospitalized with major depression, it is because they do have suicidal thoughts. So that number is not surprising, but that happens at all. But again, having gambling disorder really increased that risk notably, again, for ideation and attempts. So now that we know that people with gambling disorder are at risk for having co-occurring disorders and also at increased risk for suicidal ideation and attempts, it's incredibly important that we are screening people for suicide risk and doing safety planning. In January of 2022, OASAS put out a guidance. It is the guidance for screening, assessment, intervention, and monitoring for suicide risk and overdose risk in OASAS certified programs. There is a QR code there that if you want to take a second and take a picture of it so you have it, that will take you immediately to the guidance that is also available online. You can also type in OASAS guidance for screening and assessment, and that will sort of take you there as well. And we put out this guidance because we were aware that individuals who come into all of our programs with substance-related disorders and addictive disorders, which would be gambling, are at this increased risk. And we really wanted to make sure that people were getting screened and interventions were being made to mitigate any kind of risk for suicide. The first step in what we say in the guidance about screening and assessing for suicide risk is using a universal screen. an evidence-based instrument for discovering if someone's dealing with co-occurring mental health conditions. And the one that OASAS recommends, and probably a lot of you are using, is the modified mini screen, or the MMS, which captures 3 major areas of psychiatric conditions. So mood disorders, anxiety disorders, and psychotic disorders. It is a 22-question screening tool. You can administer it yourself, or you can give it to the patient and they can fill it out and it gets scored. And in the mood disorders question, the 4th question that's there is, in the past month, did you think that you would be better off dead or wish you were dead? And if someone says yes to this question, we then strongly recommend that you administer the Columbia Suicide Severity Risk Scale, or the CSSRS. Now, if you are in a program, working in a program where actually you just automatically do the CSSR and SSRS on everyone, that's fine as well. I know, if programs are accredited by the Joint Commission, they actually require that you do the CSSRS or a similar screen. So it's also fine if you're administering that on everyone, but some people also are doing the MMS and doing that first step. Also, the MMS is a good way to screen for co-occurring mental health conditions or symptoms. And we've highlighted that that's an important issue as well for individuals with gambling disorders, so you can use it for that piece as well. I am going to focus on suicide for this part, suicide risk assessment, but again, it's a great screen, the MMS, for really capturing all types of psychiatric conditions. So back to the Columbia Suicide Severity Risk Scale. If you've not seen it before, this is what it looks like. Again, we have another QR code that you can take a picture of that will link you directly to this very screen that we have there in the PowerPoint. And you always ask the first 2 questions: if you wished you were dead or wished you could go to sleep and not wake up. And this screens people for the past month. And have you actually had any thoughts about killing yourself? If you say yes to these 2, then you move on to the next group of questions. Have you been thinking about how you might do this? Yes or no? Have you had any have you had these thoughts and had some intention of acting on them? And have you started to worked out the details of how you will kill yourself? Did you intend to carry out your plan? So the yellow means people are low risk. So if you only say yes to these 2 and no to anything else, you are rated as low risk. Very obviously, they have outlined what is high risk. So those 2 questions about current risk, and then also, have you done anything or started to do anything or prepared to do anything to end your life within the past 3 months, is rated as high risk. And the orange is what we consider to be moderate risk. So it's a pretty straightforward screen. Anybody can administer it. You do not need special training. But in the guidance that we showed the QR code for before, if you've seen the guidance, there are links to training so you can see how it's done in action. Anyone who's rated high risk, so anyone who's saying yes to any of these in sort of this pinkish colored box, should be assessed by a licensed clinician working within their scope of practice to determine what the next intervention is. Because if someone's had these thoughts and they have some intention on acting on them, or they're making plans on how they're going to carry them out, they may be at what we call imminent risk or immediate risk for taking their life. And they may need to go to an ED or a comprehensive psychiatric evaluation program or a CPAP to get evaluated to see actually if they need a higher level of care, particularly a hospital level of care where they're able to be kept safe if they are really going to go through it. If the licensed clinician assesses someone and they do not feel that someone is an imminent risk, yes, they have had thoughts on how they might do it, but they're really not going to act on it soon, or any plan to act on it at all. They don't necessarily have to go to be evaluated. They can remain in the program, and they should make a Stanley Brown suicide safety plan in collaboration with their treatment provider. Also, people who are at moderate risk, so people who say yes to anything in the orange boxes, should also have a Stanley Brown suicide safety plan created. If someone is low risk, they don't need a safety plan created. I find I've talked to some programs where they just like to do safety planning on everyone who is low, moderate, or high risk. You can certainly choose that, but it's actually not required that people who are low risk, so just saying yes to the yellow boxes, need a safety plan. And if someone wants to do one, of course they can, but it's not sort of required. It's not felt like that it's necessary. The Stanley Brown Suicide Safety Plan is sort of the traditional one and the one that OASAS recommends that everybody use. Here's sort of what it looks like. We also have another QR code that you can use to link to it. And the Stanley Brown Safety Plan has sort of 6 steps. So that asks people to look at the warning signs that they might be in crisis and maybe leading towards having suicidal thoughts. And that could be anything, depressed mood, or maybe in this case, gambling more frequently. And you write those down and you talk to people about their internal coping strategies. So what can I do to take my mind off my problems without contacting another person? So maybe people like to read, they can go for a walk, listen to music, play music. And then you list the people in the social settings that provide distraction. So somebody's name, maybe it's a friend or a family member, their name and their contact information, or maybe it's a place, maybe going to the park. Or going to the movies. So something that will provide distraction outside of oneself. And then the people who you can ask for help during a crisis. These can be some of the same people, but a lot of times, people may fill in sort of a clinician that they work with, or their medical doctor, or someone else that they feel that they can reach out to in a crisis. And then always want to list though the professionals that are in their life, so their clinician or their agency, their local emergency department, any kind of phone numbers that you can give people locally in the community that they can access when they are at risk. And then there's also the Suicide Prevention Lifeline phone number. And the final step is making the environment safer, which is plans for lethal means safety. So these may mean things like locking up your medications or giving any sharps that you may have to a friend or a neighbor, or if someone actually does own a gun, making sure they have a gun lock so that they can keep themselves safe if in fact they do have suicidal thoughts that they are planning on acting on. Once you finish the safety plan, the patient should get the original version of it. If you are working in a program where there is a medical record, a copy should be placed in the medical record so you have access to it in case the person needs it again, and you can continue reviewing it. And you should talk with the person about where they're going to keep their safety plan and how they'll retrieve it. What we often did, my background is I worked at the VA for many years. We used to encourage people to take a picture of their plan so they had it on their phone. Seems like everybody has a phone these days, so maybe not everybody does, but that may be one way that people can bring it up very quickly if they feel that they need it. One of the things that is not changed on the Stanley Brown Safety Plan that's available widely to people, this is in the public domain, you can download it without any issues, is this phone number. So the Suicide Prevention Lifeline phone number used to be 1-800-273-TALK or 273-8255. That number still exists, but what we are encouraging people now to use is 988. So 988 is the new suicide and crisis lifeline. Not so new now, it's probably pushing 2 years. In July of 2022, 988 went live. This is a 24-hour lifeline that you can call, you can text with it, you can chat. And it really provides trained crisis counselors who will listen to you, assess the problem, and provide support and connection with appropriate mental health resources, really, if needed. So it's a great thing. It's much easier to use. It's a much easier number to remember than the 1-800 number. And we also encourage people to program this number into their phone so they can use it quickly if they need to. The other nice thing about 988, instead of calling 911, because that's what a lot of people have done traditionally or may still do when they are in crisis, is that when you call 988, you get trained crisis counselors. When you call 911, you really sort of get law enforcement. You get a dispatcher that often will involve law enforcement into the situation. And the goal with 988 is also to try to mitigate that, so really that law enforcement is not involved when people are having an emotional crisis, and that the proper people are dealing with what is going on. So when you are doing Stanley Brown safety plans, I always encourage people to put 988 as well, but you can just explain again that that 1-800 number still is functioning and will dump into the 988 line. But again, 988 is an awful lot easier to remember than that 1-800 number. So that's our information today regarding gambling and behavioral health conditions and suicide. Dr. Cunningham mentioned this at the beginning, but just want to remind you again at the end as well that there is a New York State problem gambling treatment continuum, that you have self-directed problem gambling resource centers and recovery centers. The Hope Line number is there as well. There are state certified outpatient and inpatient programs and approved private practitioners. Another QR code that you can take a picture of if you would like. And also our website, https://oasas.ny.gov/gambling. Referrals for treatment are also possible through the OASAS online provider and program search, which lists programs with a gambling designation. Again, more QR codes. And there's also the Regional Problem Gambling Resource Center. Their phone number is there in the QR code. And of course, to always keep reminding people about the Hope Line, 1-877-8-HOPE-NY. I also encourage people to put that on the safety plans for people to have that number available to them. And then finally, there are additional OASAS online resources, the OASAS Problem Gambling Clinical Resources, OASAS approved screening tools, and how to obtain a gambling designation on OASAS operating certificates. And I thank you for your time.
I want to thank the Commissioner and Dr. Hennessy for joining me today. I hope you all find it useful while assisting clients in need of services. Your feedback is important to us. It helps us to know if we're meeting your educational goals and expectations. Once you have viewed the presentation in its entirety and completed the quiz, if prompted, please follow directions to access the SurveyMonkey website and take a moment to complete the evaluation, including suggesting any future topics for Learning Thursdays. Once again, thank you for joining us and keep up the good work.